Thanks very much, Mr. Chairman. I just want to take a quick moment to acknowledge Professor Baldwin and his acknowledgement for winning this year's Vincenzo Award. I think for all of you that don't know Ian, he was actually one of my supervisors and even mentors in the early part of my fellowship training, going back maybe 13 years ago now, Ian, when I spent some time in Melbourne. So I learned a tremendous amount from Ian about RRT, about how to apply it in critically ill patients, and so I think that award is very deserving, and congratulations again, Ian. So it's great to have you here. So this is part two. This is the second of maybe two talks that I'm giving on timing of initiation of renal replacement therapy. I deliberately omitted this content from my morning talk because this is going to focus a little bit more on the most recent randomized controlled trials, and not only that, maybe the trials that are ongoing and are yet to be reported have the same clinical disclosures. This slide I showed earlier, I think bottom line is, what is our dilemma? Our dilemma is that, the optimal timing and initiation of renal replacement therapy may be uncertain, and that's because of the evidence base currently we have, and this is an important knowledge gap, because let's face it, we're treating somewhere in the range of 6 to 12% of all of our ICU patients with renal replacement therapy. So it would be ideal if we had robust evidence to help, that clinical decision-making on when's the optimal time. Small clinical trials have been published on this. I'm not going to talk about either of these in detail, in part because A, they're small trials, they're 100, 200 patients. B, they were published a long time ago, or lack generalizability to our current clinical practice in the ICU. And so I'm going to focus and start right away talking about the RRT trial, which was the largest trial published to date on timing of initiation of renal replacement therapy in critically ill patients. The RRT trial, its hypothesis was maybe antithesis to what many of us think was, basically they believed that a strategy of delayed initiation of renal replacement therapy would confer a survival benefit when compared to an early strategy. And that may be sort of, different thinking than many of the other trials whereby the hypothesis was that early initiation, in fact, may be better, an alternative view. So this was a multi-center randomized controlled trial performed at 30 centers in France. 620 critically ill patients with acute kidney injury were enrolled. They had stage 3 AKI based on the KDIGO definition, and basically had no absolute life-threatening complication for initiation of support. Generally were receiving mechanical ventilation and or vasoactive therapy. Most of these patients were medical or non-operative, non-surgical patients. And they randomized the patients to early initiation of renal replacement therapy, which was within 6 hours of achieving KDIGO stage 3. And amazingly, 98% started within about 4 to 5 hours. Or a delayed strategy, which was really renal replacement therapy in response to clinical criteria, complications, etc. It's important to note that renal replacement therapy was not protocolized and was prescribed based on French clinical practice guidelines for renal replacement therapy in the ICU. And of note, 55% of patients in this trial, their initial modality, despite how sick they were, was intermittent modalities of hemodialysis. Primary endpoint was mortality at 60 days. If you look at in the delayed arm of the trial, what were the criteria that mandated the initiation of renal replacement therapy? This is similar to the slide I showed this morning, the table that you find in any critical care or nephrology textbook about sort of the urgent or emergent indications for initiation of renal replacement therapy. This slide I showed you this morning basically shows that there was no difference in mortality at 60 days for the early or the delayed strategy, close to 50% in both, which is relatively high. There was temporal separation in initiation of renal replacement therapy between the two groups, between early and delayed, at least those who initiated renal replacement therapy, of about 57 hours. And what they showed as well is that about half of patients in the delayed strategy ultimately did not receive renal replacement therapy. There was a suggestion, and this makes sense, this is logical in the sense that there's a lower rate of catheter-related bloodstream infection in the delayed versus the early group, because the early group had more catheter days at risk, right? So it simply stated they were more likely to get catheter-related bloodstream infection to some extent. When you looked at in the delayed arm then, what were the triggers ultimately that translated into those patients getting started on renal replacement therapy, those half that did? Well, there was two main triggers, really, and this was oliguria that had persisted for greater than 72 hours, or achieving a serum urea greater than 40. These patients were profoundly azotemic. Fewer patients had hyperkalemia, fewer patients had acidemia. It seemed like it was all driven by azotemia and oliguria, whether it was fluid or not per se, but overt pulmonary edema was a less common finding. Only 6% of those in the delayed strategy developed pulmonary edema. What's interesting to me about this trial, and you have to go into the supplemental tables to find it, is that the early group, the delayed group, relative to the early group, the delayed group accumulated more metabolic complications associated with their acute kidney injury, and these were managed medically. So if you look at this table, it's quite striking to show how many patients in the delayed strategy received diuretics to manage fluid, received other interventions to manage hyperkalemia and acidosis. Like, significantly greater. And the question to me, and I showed a slide this morning, is, look, those complications in observational data have some attributable hazard and increased risk for death. But not only that, do the treatment strategies we use to manage acute kidney injury in and of themselves actually exert some hazard on the risk of death? And that's unclear. In addition, there's a couple of other findings in the Akiki trial that are worth noting. First, there was a higher rate of CKD amongst patients in the delayed arm versus the early. The delayed arm showed a greater propensity for bleeding complications not related to the catheter or GI tract. And the delayed arm actually, if they received renal replacement therapy, had a longer duration of renal replacement therapy support, or more sessions, if you like, given it was largely in the kidney outcomes. But what's important to recognize, I think, in this trial, and was not really thought about in advance for their statistical analysis plan, was that there was heterogeneity in treatment effect. That there was clearly effect modification by how sick patients were at baseline. So you can see here, this curve now stratifies patients based on their illness severity or acuity of illness. So in the early strategy, about 50% of patients died, of course, but in the delayed strategy, there became two pathways for which patients took. One pathway was that patients got better very quickly and probably weaned from their support, right? Or ultimately never received renal replacement therapy. And I would question whether these are the patients you ideally want in the trial. If you had a high probability or there was a high clinical index of suspicion that they would recover quickly, these are patients that you probably want to omit from the trial to some extent because the question may not apply to them as much. Then the other path was the delayed strategy. In the delayed strategy, which was those patients who continued to deteriorate or not improve at all and ultimately received renal replacement therapy, these patients had the highest mortality observed in the trial. So there is clearly, within the delayed strategy, some heterogeneity in treatment effect that I think has been underappreciated or minimized to some extent, and these data are all buried in the supplemental tables. Now, this group, the Akiki group, has gone on to publish a couple of sub-studies now of interest, generally hypothesis generating. One of them was they looked at the 60 patients that had CKD at baseline. This represented about 10% of patients, and they explored here the heterogeneity in treatment effect of baseline CKD status and being randomized to these two strategies. And what they were suggesting here was that mortality was higher amongst those in the early group with CKD, and they actually spent more time on a ventilator. Now, this is hypothesis generating. There's very few patients. The effect estimates are not that robust or not that precise, and certainly would be of importance to replicate in other studies going forward. They also looked at the subgroups of septic shock and ARDS, and suggested in these two clinical syndromes, on aggregate, there was no signal to suggest that early versus the delayed strategy seemed to improve survival to any great extent. The other trial that was published in the last couple of years was the Elaine trial. This was a single-center, randomized controlled trial that randomized 231 critically ill patients with at least KDIGO stage 2 AKI, who had evidence of kidney dysfunction and had one-off sepsis, receiving vasoactive support, refractory fluid overload, or worsening organ dysfunction. And it's important to recognize these were mostly surgical patients. So there's been some discussion in the literature about whether the Akiki and the Elaine trials are in fact not necessarily comparable. They're more apples and oranges given the differences in case mix. The interventions here were early initiation of renal replacement therapy, so renal replacement therapy within 8 hours of receiving KDIGO stage 2, or delayed renal replacement therapy, which was within 12 hours of achieving KDIGO stage 3, looking at 90-day all-cause mortality. I showed you this slide this morning. Basically, this trial was suggesting there was a 15% absolute reduction in mortality at 90 days, associated with an earlier strategy for initiation of renal replacement therapy compared to the delayed strategy. A couple of other findings worthy of mention would be that the early group in the ELAINE trial had a shorter duration of renal support by 18 days, actually showed some trends for greater kidney recovery that were not evident in 90 days but were evident within hospital. A shorter duration of mechanical ventilation by approximately 2.5 days. No difference in ICU stay though, and a duration of hospital stay that was shorter by 37 days, more than a month. So I have some question about the generalizability of the findings around ICU and hospital stays in trials such as this, because there may be health system factors that impact how long patients stay in hospital that may be independent of any intervention that was received proximally during their stay. But they also showed some interesting data to suggest that the early initiation of renal replacement therapy had a positive effect on greater clearance of some pro-inflammatory mediators, particularly IL-6 and IL-8. Again, providing some biologic effect that may have translated or have been at least partly attributable to the clinical effect observed. Some other considerations, again, I mentioned mostly surgical, in fact, mostly cardiac surgical. The delayed strategy, what was interesting is that nearly all of them worsened to go on to receive renal replacement therapy. So only 9% in the delayed strategy did not receive renal replacement therapy. That's in stark contrast to the Akiki trial, where it was close to 50%. So clearly there may have been some fundamental differences in how the trial approached and enrolled patients. In the delayed strategy, an absolute indication based on the classic sort of triggers for initiation of renal replacement therapy only occurred in 15.1% of patients. Again, re-emphasizing the idea that we see those triggers less often in critical care when we initiate renal replacement therapy these days. And the primary endpoint, it is worth mentioning that the observed effect is implausibly large. A 15% absolute reduction based on a 21-hour difference in initiation of renal replacement therapy in a cohort of surgical patients seems like an implausibly large effect, and the authors suggest this and certainly call for further replication of their findings. Now, Alex and his colleagues did actually sort of publish the 1-year long-term outcome evidence from the ELAINE trial, and it suggested that there was preservation in the survival effect going out to 1 year, as you can see there. Now, there are some other trials that are ongoing right now. This is the IDEAL ICU trial, which was another French multi-center randomized controlled trial, now focused on 864 patients with septic shock. That was looking at early initiation of renal replacement therapy within 12 hours of achieving rifle category failure, or delayed strategy, which mandated 48 hours transpire before initiation of renal replacement therapy, looking at 90-day mortality. This trial was terminated prematurely after approximately 56% enrollment, and is currently under review at a journal. So we'll hopefully have some data to show for this in the near future, but terminated early for futility would suggest that there may not be a strong signal one way or another coming from the IDEAL ICU data. That brings me to the START AKI trial, which I have, in full disclosure, I'm a co-PI on. And our research question really was, does accelerated or early initiation of renal replacement therapy in critically ill patients with AKI reduce 90-day all-cause mortality and renal recovery? And we actually did a pilot study to try to inform about the protocol that we would use moving forward for a more definitive multinational trial. We enrolled 100 patients at 12 sites affiliated with the Canadian Critical Care Trials Group, and really looked at feasibility endpoints, protocol implementation, 90-day mortality, etc. As part of this protocol, one of our eligibility criteria was having to have achieved a serum NGAL value greater than 400. We thought including, as an innovative approach, a novel biomarker for kidney damage might help enrich the population at risk for the intervention. And I'll show you some data here. Basically, this is the cohort of patients allocated by accelerated versus standard. And I want to emphasize that these patients were sick. 50% or more had sepsis. SOFA scores were 13 to 14. Almost all of the patients were ventilated and on vasoactive support. The biochemical parameters of AKI were largely aligned with the renal trial. And you can see the NGAL values there. The median values were greater than 1,300 in both groups. So we identified a patient population who clearly had acute kidney injury. However, the NGAL value here did not help us discriminate who to exclude from the trial per se. And you can see here, we randomized these patients. 100% of patients in the accelerated arm received this renal replacement therapy early. In the standard arm, it worked out to be approximately 37%. The timing of initiation, we had good temporal differences by greater than 1 day. 90-day mortality was only 38% in our trial. Again, knowing how sick they were, and then looking at Akiki and Elaine, it's interesting to note that our mortality is anywhere from 10 to 15% lower in our trial compared with theirs. So there's some generalizability issues that will have to be played out and really dissected carefully. ICU stay was a little bit shorter by accelerated renal replacement therapy, and total hospital stay was about 29 to 31 days. Again, when you look at Elaine, when their total hospital stay in the standard or delayed arm was exceeding almost 80 days, you have to ask yourself, what are the fundamental differences? And hospital length of stay may not be a very robust or sensitive endpoint. But we proved that the trial was feasible, that it was safe, and really used these event rates to inform the main phase of our trial. There was some clinician or investigator discomfort with the idea that 25 to 35% of patients randomized to the standard arm would not receive renal replacement therapy. And based on this premise, we had to ensure clinicians who had equipoise that they could enroll these patients and they weren't providing unnecessary renal replacement therapy. So 2 strategies were employed. One was the clinician veto to ensure equipoise was present, and the other was to integrate into our definitive trial the idea of a furosemide stress test that they could use as an ancillary test to help inform whether patients would ultimately get worse or not. We didn't feel that we could continue to include the NGAL values because basically it identified everybody to some extent. So the furosemide stress test is an interesting idea. This is a single-center trial that was published in Thailand, and looked at using all patients screened for eligibility had an FST administered, and then they weeded out some patients based on a non-response or responsiveness to a furosemide stress test, and then randomized the patients to effectively the exact same protocol that we had in START-AKI, right? Early versus standard initiation of renal replacement therapy. And what's important to recognize is that FST excluded about 27% of patients, and these patients did have a lower likelihood of going on to receive renal replacement therapy and had a lower mortality overall. So this might be a useful sort of clinical measure, dynamic test that could be used to determine whether patients ultimately are going to worsen over the subsequent 12 to 24 hours and help you decide suitability for renal replacement therapy or not. So I want to get to the START-AKI trial, which is a multi-center open-label randomized controlled trial of accelerated and conservative strategies for renal replacement therapy with a planned enrollment of 2,866 patients. The program of research actually started when I was a clinical fellow in Australia with Ronaldo and Ian. So the first time we started addressing this issue of when to optimally start was more than 10 years ago. But you can see now this has been a major collaborative effort and multinational involvement. And as it moves forward, I can tell you that we're enrolling adult patients admitted to ICU with evidence of kidney dysfunction, and the criteria are largely aligning with KDIGO Stage 2 AKI criteria. We're excluding patients for which there is no equipoise, so patients who have life-threatening metabolic complications are out, or those that have a low probability of not having classic AKI encountered in the ICU, such as RPGN, etc., or advanced CKD, or have been previously treated with renal replacement therapy. A unique aspect that we've integrated into the large main phase of the trial is that we wanted to ensure that clinicians have equipoise. So clinicians do have the opportunity to veto patients if they feel that immediate initiation of renal replacement therapy is required, or if deferral, in fact, would be mandated. So clinicians, if they have a high probability of expecting imminent recovery of kidney function, can veto patients being enrolled in the trial. We tried this in a pilot study, and clinicians were correct 4 times out of 5 in being able to predict renal recovery. And that's based on trajectory of illness severity, response to initial resuscitation, other things that are hard to actually protocolize in a randomized trial. But we believe that the clinicians must have equipoise. We do this not to reinforce their clinical practice, but to ensure that, if there's patients that has a low probability of ever receiving renal replacement therapy, we weeded them out of the trial, which I think was one of the limitations perhaps of the key. So this is how the trial looks. KDIGO Stage 2, no urgent indication and equipoise, randomized to accelerated versus standard. All aspects of renal replacement therapy, once started, are pragmatic and based on local standards of care and current best practice. We're looking at 90-day all-cause mortality and a series of secondary endpoints that look at renal replacement therapy utilization, other health services use, ventilators, vasoactive support, ICU, and hospital lengths of stay. but also a formal health technology assessment and health economic evaluation of the two strategies. I can tell you to date, there's 126 activated sites around the world. We've randomized 1,903 patients, about 2/3. We hope to be done at this time next year by this meeting. So a few final thoughts for you. The issue of who, when, and under what circumstance, again, to ideally initiate renal replacement therapy for patients who are critically ill with AKI. The absence of those life-threatening complications is an important evidence care gap. Much like Claudio had mentioned previously, we're learning about how best to inform clinical practice based on randomized trials, but there is an element of sort of patient-centeredness that has to go into these clinical decisions that we make at the bedside. I think Akiki and Elaine have been major contributions to helping understand this controversial issue, and perhaps some of the weight might lean towards Akiki saying, look, a personalized approach, one that might include watching and waiting, may be an acceptable strategy for many patients. But I would argue that additional randomized trials are needed, particularly to harmonize the findings between the discordant trials. And we're hopeful that Ideal ICU, to be published hopefully very soon, and that START AKI completing in the next year will help inform this practice.